Hi everyone from N261 class. This is Dr. Pam Williams. I'm going to finish the recording of the vital signs lecture, starting with respirations. I was a little late to the party for the first section, so for sections 2 and 3 this will be a nice review. So when counting respirations, they really should not be audible whenever we're standing next to the person, and we really should need a stethoscope to listen to respirations. So if we are just listening in our observation, then those respirations are really abnormal. So whenever we are going to be counting respirations, you take the person's hand and I hold it over their chest and I count respirations first for 30 seconds if the respirations are regular, and then for the second 30-second portion of that minute I'm going to counting the pulse. It kind of has people not thinking of how they're breathing for that first half, whereas they might breathe differently when they think you're counting their respirations. This ratio of 4 to 1 is not something to really count on. If a person's pulse is 80, then that would mean the respirations are 20. And if we think that normal respirations are 10 to 20, they're at the upper limit of respirations, but they're right in the middle for the expected pulse. So just kind of take that as maybe just a rule of thumb and not hard and fast facts. Please know that when a person is anxious or does exercise, then both their pulse and their respiratory rate is going to increase. We're going to expect to see that. So when taking a blood pressure, this is what we're measuring is the blood pushing against the side of the vessel wall. In certain situations, it's going to be quite variable. Everyone is very dynamic. So a blood pressure, a pulse, a respiration, even the pulse ox, which we'll talk about later, is always going to be changing. That's what dynamic means. So we're going to be taking their blood pressures frequently throughout the day, perhaps, or even a couple minutes apart. We're going to be looking for two numbers specifically, the systolic pressure, and that's how much force it takes for the blood that's been occluded in the artery to push past that and start flowing. Then the diastolic pressure is that pressure that remains when the cuff is relaxed, and that's just how much pressure the person normally has in the arterial system. With hypertension, that pressure is going to be increased, and with hypotension, it's so low there's almost no pressure behind that blood, and the blood might not be moving adequately. So the pulse difference is that difference between systolic and diastolic, and how much blood is forcing through that artery may determine how wide that difference is. And the mean arterial pressure is something that is averaged over the cycles, and we really use that with a Dynamap rather than doing all the math calculations of our own. So whenever we're taking a blood pressure, we really think that a normal or an average is 120/80, but this can so vary with so many things like age. A younger person might have actually a lower pressure. It can kind of climb to 120/80, and then as a person ages beyond 65 or 70, that normal pressure, that what we would expect to see, may kind of look pre-hypertensive or stage 1 hypertensive, but that's just a normal factor of age. After puberty, females are going to show a lower blood pressure than male, kind of like their pulse is going to be lower, actually faster than a male's is going to be. And after menopause, females look a little bit higher than a male does. Race, a blood pressure in an African American person is usually substantially higher than a white person of that same age, gender, and body size. So we have to be very careful in taking blood pressure of different races, different ethnic groups, and teach them about blood pressure and how to maintain a healthy blood pressure. So we've got these 5 factors that really show what a blood pressure is made of, and this cardiac output. So if the blood, that's the stroke volume, pumps more blood into a vessel, that pressure may be increasing. And again, each heartbeat pushes out about 70 mLs, or a little bit more than 2 ounces of blood. The peripheral vascular resistance is how much resistance is given. So are they occluded? Is there cholesterol in that vessel? Is it shrunk by another reason? Is there a tourniquet on? Is there a tumor pushing nearby? Kind of lots of reasons why there might be resistance in that vascular system. The volume of circulating blood. So this is not just how much blood is put out at each heartbeat, but how much volume there is. And so is there a large volume? Is there a lesser volume? How much blood is in the artery? and the blood pressure is in the arterial system more than the venous system. The thickness of the blood, if a person has a lot of edema and the plasma, the fluid, is forced into the interstitial tissues, then their pressure might be a little bit higher or lower because there's not as much volume in that blood. The elasticity of the vessel walls, if they're stiff and rigid, the pressure may be increased because there's that much more resistance. So all of these factors can go into making up the blood pressure, and when a blood pressure is not what we would expect, whether it would be regular for an age or a gender, then we have to consider all of these factors. So we're going to be using a stethoscope and the aneroid sphygmomanometer. It really does have to be calibrated, and make sure that whenever you're looking at the gauge, the dial is at 0, or the thing that moves, the arm, the hand, is at 0. Whenever we look at the cuff, there's a length to the cuff and the width to the cuff, and the width of the cuff should not be more than 40%, which would be less than half of the person's arm, and the length of the bladder, not the whole blood pressure cuff, but just the bladder, should be about 80% of that circumference. So that's going to tell us what size cuff we use, whether it's a pediatric cuff for an adult, which is possible, the average adult size, or an extra large blood pressure cuff on a person who has a larger arm. So in 2 steps we're going to be taking this pressure. Not always is this done, but really this is the right way to do it. This is the way we're teaching. So we're going to put the cuff on about 1 inch above the brachial artery. Then we're going to palpate that artery and inflate the cuff, and note on the dial when we can't feel that artery pulsating anymore, and then we're going to release the pressure on that cuff. We're going to wait this 15 to 30 seconds, have the person move their arm or just squeeze and open their hand to make sure that the blood is moving again. Then we're going to put this bell of the stethoscope. Your book used to say just the bell. This newer edition says bell or diaphragm, because truly a lot of nurses, probably 3/4 of the nurses, maybe even more, use the diaphragm to assess a blood pressure, and you can pick it up. But truly, if you're having difficulty with the blood pressure, you're going to use the bell, because what we're doing is creating disturbance, and that's what a bruit is, when there's a disturbance of the blood flow. So the bell is the best to hear that low sound, right? So we're going to be using the bell if we have it. So we're going to put the bell, or diaphragm, over that brachial artery. We're going to be inflating the cuff 20 to 30 millimeters of mercury beyond that point when we found it disappear, and then we're going to slowly open the stopcock and let it slowly move down. The hand move down. This says 2 millimeters of mercury per heartbeat. That's kind of slow, so you could do this 2 millimeters until you hear a heartbeat, and then maybe a little bit faster, maybe 4 to 6 millimeters per heartbeat while you're still hearing it. And then when you get this muffling or this lower, maybe slow it down so you're actually getting the point when you don't hear this heartbeat anymore. In class, I demonstrated where you hear the boom, and then the boom, 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 and it's going to be louder and louder as you get to the middle of the blood pressure, and then it's going to start muffling, and then you're going to disappear. You're not going to hear it. So you're going to have to note when the last time you heard it, because you never know when the last time you heard it. So those last couple blood pressures after it, or numbers after you hear the muffling, you're going to really note where it ends. We're going to be listening to the first Korotkoff sound and the last Korotkoff sound. If that last sound goes all the way down to the bottom, then we're also going to be listening for this muffling and give them a 3-number blood pressure. So it'll be the 1st, the 4th, and the 5th. So for all age ranges, this 5th number is what we're going to be using for a blood pressure. Sometimes we used to use just the muffling. Clear communication is really important so that we can tell that person that we've heard the sound all the way to the end, and that's why we're having this 3rd sound. So this is an important screen. Unfortunately, the first one, this hypotension, your book says anything less than 90 is going to be hypotension, and here you see the 96. So just know that it's 90 or less. Normal or anticipated or regular is 120/80. So then pre-hypertension is anything above a 120/80. So a 122/82 could even be prehypertension. Although we look at the person, we look at the size, we look at the age, we look if they're athletic, if they're fit. Please know, and this is this last piece, but I want to say it now, that if any part of a blood pressure is outside of what we would expect a range of hypertension, stage 1 hypertension, stage 2 prehypertension, then the whole blood pressure is at that point. So you can't have like a normal number, like a 118 over an 86. We would call that prehypertension because one of those numbers falls within that range. Don't think that it can balance itself out. So the prehypertension up to 138/88, stage 1 hypertension 140/90 and higher, and stage 2 hypertension 160/110, and then as high as that's going to get. And again, if one number is off, the whole blood pressure is off. So orthostatic or postural vital signs. If we have a person who says they've been fainting, or a person who has lost a large amount of blood, and syncope is pretty much the same as fainting, or someone who we really know has hypertension or even hypotension, then we're going to use these 3 measurements of blood pressure called postural vital signs or orthostatic vital signs. We're going to take them when they're lying down, when they're sitting, and then when they're standing. And pretty quickly, as soon as they change to that position, we're taking it so we see what the body's doing before it gets a chance to regulate itself. So they're at rest on their back, supine on the spine, and we take the blood pressure. Really important that, again, this arm is at the level of the heart and that we're not holding their arm up. So we're taking it when they're lying down, when they're sitting, and then when they're standing. And if the person can't stand without fainting, then we're using sitting with their legs dangling, because we want to see how much blood is being lost to their peripheral vascular beds and doesn't have the pressure to keep the blood circulating. Of course, we want to know what pressure was taken, at what position was being used, the cuff size, and anything else that we would note. And then be taking their pulse as well. So in children, they're going to have their blood pressures, all their vital signs taken, the same reason post-op after an illness as ordered as an adult would be. When we're thinking about babies and taking a temperature on a baby, we are going to take that last in the order. Instead of a temperature, pulse, and respiration, we're going to hold that off to the end. And respiration is just an observed vital sign, so we can do that without disturbing a child. And even the pulse is really a heart rate, so we're going to slip the stethoscope down to the apical area and listen to their heart rate. For babies, we take it for 1 full minute. So it's not that we're listening for just a half of a minute, and then we're taking their temperature, whether it's axillary, tympanic, or the temporal, but it's usually just a tympanic or an axillary. We're going to avoid that rectal route on most people, unless, again, they can't, for some reason, have it taken temporally or axillary. It just says that whenever a child is old enough to hold it in their mouth, it could be 5 to 6 or even a 4-year-old. So that opens up that a 4-year-old who can cooperate can have their temperature taken orally. And then, of course, an adolescent is hardly a child or an infant, so they're considered to be an adult. So when we take a rectal temperature with a child, they're going to be again, any same reason that we couldn't take it axillary or temporal. So it would really be more that they wouldn't be cooperating. But really, if you can't cooperate for a tympanic, can you cooperate for a rectal? So an infant, a newborn, we're going to have them on their back with their knees flexed. And this says to insert the lubricated covered thermometer 1 inch, and that's quite high for a newborn. Depending on their age. So really you're just inserting the tip of the probe, and maybe a millimeter more than that is all you need to do. A whole inch on a newborn is going to be quite high. And newborns are going to have a higher temperature. So instead of like a 98.6 being normal for an oral, or a 99.6, I have to always think, for a rectal, 100, which really isn't that much more than 99.6, maybe a little bit higher. And then knowing how the diurnal changes are going to happen for time of day and such. So pulse, heart rate, and respirations. We're going to be again taking that apical rate for infants. We're counting for that full minute. All heart rates are going to fluctuate with movement, emotion, and illness. So we have to take that into consideration. Respiration.